The government has announced a deal that will allegedly end the dreaded 8 a.m. scramble for GP appointments by shifting the booking process entirely online. The move, part of an £889 million reform package, aims to make booking an appointment more accessible and ensure continuity of care by enabling patients can see their regular doctor more consistently. But is this the revolution patients have been waiting for? Is it yet another bureaucratic reshuffle designed to create new problems? The Health Secretary, Wes Streeting, has declared that the rebuilding of the broken NHS starts with primary care, and under these reforms, their GP surgeries must allow patients to request appointments online from October, freeing up phone lines for those with urgent medical needs. And this, combined with a reduction in red tape and a focus on patient continuity, is meant to alleviate pressures across the NHS. For many, this shift sounds like a sensible embrace of modern technology. Online booking could, in theory, create a smoother, fairer process, especially for those who struggle to call in peak hours. The reform also proposes incentives for surgeries to prioritise regular patient-doctor relationships, aiming to restore the concept of the family doctor. But this policy assumes that all patients have reliable internet access and that digital literacy is consistent in determining whether or not people can navigate an online booking system. For elderly patients, those with disabilities, individuals from low-income backgrounds who may not have smartphones or internet access, this change could exacerbate existing health inequalities. Additionally, past attempts at digital-first healthcare services such as NHS 111 Online and e-consult have faced criticism for being overly complex, difficult to access, time-consuming and resulting in misdirected care. The concern remains that an over-reliance on online booking may create barriers rather than remove them. Streeting has framed this reform as a way to reduce GP burnout by cutting bureaucratic problems, by cutting these bureaucratic burdens, and reducing performance targets from 77 to 44 may indeed free up some clinical time. However, the fundamental problem in the NHS is a shortage of doctors, not just inefficiencies in how appointments are made, a shortage of doctors because more doctors are training in the UK, but more are leaving the NHS because it's an intolerable place to work. Why? Because of the bureaucracy, because of the mountain of bureaucrats pouring out bureaucracy by the minute. Without addressing recruitment and retention issues, any system, online or otherwise, will be inadequate to meet demand. And the reform's promise of extra funding doesn't change the reality that many GP practices are closing because of financial pressures, leaving remaining surgeries overwhelmed by having to pick up the additional group of patients. The idea that online booking will solve these deeper issues is optimistic at best, therefore. And one of the headline promises is to bring back the family doctor, the GP who regularly sees the same patients, fostering continuity of care. While continuity is undoubtedly beneficial for patient outcomes, this requires an increase in staffing levels. And with GPs already stretched to their limits, expecting them to provide more personalised care without additional personnel seems unrealistic. The plan to financially incentivise surgeries to prioritise continuity is an interesting proposal, but given the current crisis in GP recruitment, one wonders if the necessary workforce exists to implement this vision effectively. Despite these concerns, there are potential advantages. Freeing up phone lines by shifting routine bookings online may improve access for those with urgent health needs, and the removal of excessive bureaucratic obligations could allow GPs to focus more on patient care. If properly implemented, this reform could create a more streamlined and equitable system. And the shift to online GP appointment booking is not inherently a bad idea, but its success will depend on execution. And without careful attention to accessibility, digital exclusion, and the underlying workforce crisis, this policy risks becoming another well-intentioned but ultimately ineffective initiative at great expense. For those with reliable internet access and a straightforward health history, this system should be a welcome improvement. For the rest, particularly the elderly, the disabled, the digitally excluded, it may create yet another obstacle in an already overburdened system. The real test will be whether these reforms address the structural issues within general practice or merely shift the bottleneck from phone lines to internet queues.